Hello, and welcome to Stories in Innovation in ALS. My name is Lisa Deegan, and I'm joined today by my co-host, McFinn Levere. We've both been affected by ALS, so we helped co-found a nonprofit called Everything ALS, whose mission is to bring citizen-driven research that merges technology and science to help accelerate treatments for ALS. This podcast brings together stories of those affected and those who are accelerating treatments for this devastating disease. Today's episode, my dedication to study and care for people with ALS, shares Dr. Merit Cudkowicz's journey. Dr. Cudkowicz is the chief of Massachusetts General Hospital Neurology Service, the director of the Sean M. Healey and AMG Center for ALS at MGH, and the Juliet Dorn Professor of Neurology at Harvard Medical School in Boston. She directs the Mass General ALS program. She's one of the founders and former co-directors of the Northeast ALS Consortium, and she is leading the first platform trial initiative for ALS. Her research and clinical activities are dedicated to the study and treatment for people with ALS. Thank you. So we're so honored. We so appreciate your time. It's so valuable. You do so much for others. So for you taking the time to share your journey with us, we're completely honored. So thank you. Thank you. Can't thank you enough. So we'll dive right in. McFinn, let you start.
Yeah. So Dr. Merritt, I know you probably have a long history of caring for folks, but when did you decide that ALS was the focus of what you wanted to accomplish?
I decided that when I was a resident in neurology at Mass General Hospital, it was in the mid-90s. The first gene had just been discovered for ALS, the SOD1 gene by Dr. Brown. And everybody was talking about how maybe there would be treatment now, that there was like, some clue into this. And I was just like, this is what I want to do. I want to try to find treatments for ALS and also, some Huntington's, Alzheimer's, all these kind of serious illnesses that we had no clue about. So but that's how it started.
Is that really what started the research at Mass General in general? Just the fact that Dr. Brown, you and the whole team discovered that connection with SOD1 and ALS? Is that kind of what kicked off the focus, even just not within your own research, but with that MGH in general?
Yeah, I think Dr. Brown was there long before and was looking for these genes and doing this. It was much harder to find genes back then than it is now. So mapping all the families and collecting the samples and doing all the genotyping. But and he was seeing all the patients, and so he took me in as a fellow to teach how to care for people, but also to help bring some of these trials forward.
And 30 years later, we have 30 identified genes, or is it more than that? Or
it's actually past 45 now.
Oh,
and
whoa!
They think they know 70 to 80% of the families, but there's still some families that they can't find the cause for. But it's been amazing progress, and I think now, I was young and naive back then. I thought the treatments around the corner. I actually think they're around the corner now.
Well, we're closer now than ever, I would say, for things like the HEALEY Platform Trial and all the efforts of everybody bringing out everything together. Would you say, I'm just curious, I know the Healey Center is working, and it even said on the website, over 500,000 people worldwide that are affected by ALS. When I look, when I do my own little research, just Googling, how many people in the US have it? Some of the numbers are 20,000, some of them are 30,000. Just based on people that I know who have been affected, even, me being one of them, because my brother passed away from it, there's got to be more than this number. Do you have a more accurate number for us, just to get a more accurate sense of really how many people are affected by this? I just got to believe it's higher.
I think it's higher too, and I would put it more in the 30,000s. But the issues that we don't really know. So we have a couple tools like the registry, the CDC registry. But I think there are people who are still not getting care or diagnosed out there with ALS, and so that's why I think these numbers are underestimate.
Do you think it's because people don't know? Do you think that's part of the challenge? Is they don't? It takes a while to get diagnosed, and they bounce around from this specialist to that by the time they get to a neurologist. You think
We have
that's
to
part of it?
solve that problem. I mean, we really do. I mean, it's still taking a year from the first symptom to diagnosis on average. And it's just what you described, that people are going from one doctor to the other. I
Mhm.
kind of compare it like if somebody with a relatively rare cardiac problem came to me, I would probably miss it. So it's they're seeing doctors who never see people with ALS, so it's not on their mind.
Sure.
But I think we have to solve it because we really, I mean, there's more and more data suggesting the earlier you intervene, the bigger chance you have of having a big effect. So plus just the anxiety of not knowing what you have for a year.
For
That-
sure. Would you,
That sounds like our speech project is going to be part of a real winner. Do you see that? Do you ever see yourself using that?
Yes, I do think so. I think that, yeah, that will help us. Yeah. And maybe it's speech for some people and will be some other digital device for others. But I do think that we could use this kind of technology to get faster diagnosis and
Yeah.
education. I mean, some is going to be low tech and then some is high tech.
So Merritt, with the HEALEY Platform Trial, this has been really groundbreaking work in ALS, bringing all the experts together. And actually a lot of the people on your scientific advisory board and on your HEALEY Center team have been able to present on our platform, which has been so wonderful. So how would you say the center came about, and do you want to share any personal connection that you had to this coming together?
Sure. Our clinic and our program here has been around since Dr. Brown really found it, and all of us learned from him about how important putting the person with the illness front and center and doing everything you can, and so that's always been kind of the way we've operated here. And then I got a call from a couple people about asking if I would see Sean Healey. And I said, of course. And, I actually had a phone call with him on a weekend and we started talking. He came right away and he just decided, he said, this place cares, and this, I want to help others. And I need a place that has the same mindset I do about speed and efficiency and collaboration and breaking down barriers. And that was transformative. I mean, for I think, because we had been thinking about these big ideas of platforms and how can we keep, speeding things up. And so to be able to have a gift of that magnitude, to be able to launch this platform trial was, we wouldn't have been able to do it without someone like that to support us. And I think someone asked me the other day what I do for my career, and it's not very scientific, but I do kind of try to break down barriers that slow progress. Like we brought, for example, a central ethics board to our trials a couple of years ago, because I was launching these trials and it would take a year to get like all 50 sites, approved by their ethics board. And it seemed ridiculous to have, 60 different groups weigh in on the ethics of the project.
Sure.
And the opinions were, vastly different. So we brought that to our network, and that cut down startup time, from like 12 months to 3 months.
Is this the IRB that you're talking about? Which was brilliant, because we know just from our speech study to get that done, there's a lot that's required to get that done. So if you had to do that on multiple sites, that's a lot of work.
Yeah.
So
this seemed like the next step is that then it seemed inefficient every time we do a trial, then we have to do another when we start all over again. So anyways, it's been about like as the science gets better and better and we get better drugs, how can we make sure we don't spend like, months, before we can get them to people? So the platform trials seemed like the next efficiency. And I'm sure there's more, even more things that we could speed up.
Well, we could all say that with anything, and it is a learning process as you go along. How many active trials would you say? Are there approximately like 70 active trials?
Yes, I've lost count. I mean, I used to be able to know them all. At our center alone, I think we have like 14. So we have like these spreadsheets and we have huddles at the beginning of clinic, and we have a research navigator nurse to tell people about studies. But I think that's hopeful. That means that there's a lot of really good ideas out there.
It sounds really
so-
hopeful that you have all of that information available. Do you print that out for ALS patients? How much
Yes.
work? And do you have little folders in your office that they take out off the wall and check out?
Yes, yes. Now, everything we give out like that has to be IRB approved, but we have a language for each of our trials that describes it, that we can put in a brochure to hand out to people.
Great.
It's nice people that if they go to MGH, they know that they have a place that they can go for care and research and trials. I know from my personal experience when my younger brother was diagnosed, and we live in Silicon Valley, and he went to Stanford, and they just basically said, well, get your affairs in order, and I'm sorry. So my brother had no hope. So we didn't have a close family member who had it. So we were going through it for the first time going, what the heck do we do? And we just went based on what my brother thought, like, well, forget it. There's no hope. I'm just going to go home. And he did research some alternative treatments. But if I would have known of the HEALEY Platform Trial, I would have said, let's go, let's get on a plane and let's do this. So I think I had mentioned to you also, my girlfriend from college, her mom, Virginia, what was her last name? Is Susanna Adelson was my friend. So her mom, Virginia, was your patient.
Oh, yeah.
And she just loved you. Yeah. So you are referred to as the godmother of ALS. Do you know that? Do you know that people say that about you?
I just hopefully I want to be the grandmother, but I'll take like that. Yeah. But I feel like it's not a job. It's like it's a community that's kind of working together to solve this, and it's beautiful. And the people we meet are beautiful.
But it's so wonderful that the people who you call patients are actually going to be some scientist for you and give you some feedback, and making the patient feel like they have a foot in the game is it's powerful. When I hear people say, my doctor is really trying, I really have faith in him. So that brings me to a question. There's no cure, but is there any medication that you feel is the best that can be given to somebody with ALS?
Yeah, that's a great question. I mean, I think there's a cocktail of medications that are the best things to give. And so I usually, I think of it this way, like there's 3 or 4 drugs that we have pretty good data in people that they can slow down the illness. And then there's a group of drugs where we have phenomenal science in the lab, but we don't quite know yet if they're working people. But I think people should be on all of the first category and at least 1 or more of the second category. To give the best chance of really like stopping or slowing this down. So the ones on the first category, I think obviously riluzole, Radicava, the Amylyx drug, and also I think this high dose B12, which is or methylcobalamin, which is a study from Japan. So I typically recommend those. It's like at least we have good data in people that they might do something. And then the next step is like a trial or compassionate use or something.
And with 90% of people who come down with ALS being sporadic, it's at least 90%, right? And it's such a heterogeneous disease that makes it even more complicated. Do you find that there's probably a ton of different cocktails? And when we use cocktail, I use that loosely, combined with treatments or therapies, because it's layered, right?
Yes.
I mean, that adds a whole layer of challenge for you guys.
Right. It might be a different cocktail for different people, and then also in different parts of the illness. And what we're hampered by is not having like the biologic tools to know, like what everybody talks about, these biomarkers, to know if somebody is responding to a treatment, like in a short time. So we have to wait clinically to see it. But I think we're getting there. I mean, that's there's a lot of people working on different, fluid or digital or, like what you said, the speech things, ways to really see if we're making an impact in a short time.
why do you, and I'm clearly not a doctor, but why do you think that we can't find a biomarker in blood or even spinal fluid that makes it really simple? Because most things can be detected in blood. And maybe I'm wrong in saying that. So why is it so difficult? I mean, it clearly is, otherwise you guys would have had all the answers.
I think it's not unique to ALS. It's hard. It's also hard for other brain diseases. I think that it's hard because not everything that's going on in the cell leaks out into the spinal fluid or the blood.
Okay.
And we obviously don't want to do biopsies. But
Okay.
I do think that technology's gotten better, that we can measure smaller and smaller quantities of things in the spinal fluid, and we can measure secreted things, something called exosomes. There's
Mhm.
lots of great data coming out of that from there. So, and I do think we could do more in imaging.
Okay.
Imaging has really changed. Like, for example, for Alzheimer's, they have these different PET ligands that they can see the biology happening 20 years before cognitive changes happen in that disease. We don't have those type of tools in ALS.
So the blood-brain barrier makes it more difficult, really.
Yes. Yeah.
Okay.
But
Well, wouldn't that be great if we could get imaging that you could go in and get a scan? Wouldn't that be nice?
Yeah, so there's groups, there's an international kind of imaging consortium, trying to develop some of these, but we're a little late. I'd say that it's a recent thing as opposed to maybe Alzheimer's and Parkinson's. They've been working on imaging tools for a long time.
Yeah,
The
okay.
example I like to give is multiple sclerosis. They have like 20 drugs on the market. The whole field has changed, and in a really good way. But the pivotal moment for that disease was the imaging biomarker, because all of a sudden they could screen drugs in a very short time, and they knew if it changed the imaging marker, it was going to change clinical course. So drug development just sped up.
Yes.
And we don't have that.
We need a win like that now.
Yeah.
I think it's around the corner. I'm really hopeful.
Well,
So
I have an idea, Merritt.
Yeah.
Since the military is having so much ALS, shouldn't they be coordinating with you to, like, say, how come all of our men, not all, but how come a great number of our men are getting ALS? What is it about us in the military that's giving them ALS? Have you looked into that?
Yeah. No, I haven't personally done any studies, but people in my group have, and I absolutely agree with you. It's a clue in there of what might cause it, and also opportunity for them to fund some of this research, which they're certainly doing, and I know they've increased the amount, but we might need more to figure this out.
Yeah. So with telemedicine becoming really big during COVID, and I know that's actually part of, because you guys are really innovative in the way you try to take care of your patients, you were actually doing telemedicine calls before COVID. Is that right?
Yes, we had started a long time ago. The hospital was really encouraging us to do it, not just in ALS, but in all illnesses. And then it took off with COVID.
So this is hopeful for people who may be listening to this or have heard about you from our webinars or all the other great resources that are out there. And does that, there's a better chance of getting in to see you with telemedicine being available, or is it still kind of
it's
a
still tricky, and I do think it's something that we need to advocate for. I know we have other really important things to advocate in the government for, but this has to be on the list too. Before COVID, I think because not that many people were doing telemedicine, nobody really was paying attention about it or complaining if you saw someone in the state that you weren't licensed in, because it wasn't happening that much. Then COVID allowed it, they got rid of all the rules. You could see anybody telemedicine in any state. And then they clamped down on that again. So now you're not allowed to do telemedicine if you don't have a license. And that really hurts rare diseases or serious illnesses where travel is hard, like ALS and other ones. So now, we're getting licensed everywhere, but that's enormous expense and time. And medicine isn't different across state lines. So but it's going to take a big intervention from the government to change that.
Well, there's definitely a little bit more work to be done, but I'm sure we're all heading in that direction, hopefully, and I'm sure people are fighting for it. So I do have a question because it says that you guys are really focused, the Healy Center is really focused on cure, controlling, and preventing ALS, which are three very important things, right? Because obviously if you don't have a cure right now, then let's try to prevent or control. So what do you think you guys have? I think you've been successful in so much, but what would you say has been some of the biggest successes in terms of that?
Yeah, I think so. For the kind of controlling, I think the the amyloid drug is the most recent success. I mean, it does add another slowing of the illness by a third, and might even have a bigger effect. It started early.
Yeah.
So that's
Yay.
I do think that I hope some of these other drugs in the platform trial or other trials will also be successful, and we're going to have many of these read out their results in 2022. So I'm hoping for a couple more successes.
Yeah.
Also, I think now we have a clearer path for FDA approval. I hope an accelerated path. I think there's been great progress on that. I think the other categories, like I think about repair. And we used to never think about repair in ALS, but now we're talking about it. And I think there's more and more scientists coming, for example, from spinal cord injury or stroke repair, thinking about ALS repair, like how, if we do slow it down or we do stop it, how can we give people back function? So that's more in the lab space, but there are some companies with drugs around repair for ALS.
That's brilliant. Because as of right now, if a neuron dies, it's gone, right? For the most part.
Be completely gone. It's disconnected. It might be disconnected from the muscle.
Okay.
And so then the question is, can you help that kind of regrow and reconnect?
Yes.
And so I think the more we can attract scientists from other areas thinking about this to ALS, that will help us get ready. So, but anyway, I do think in 2022, we'll have our first kind of drugs that are on that repair pathway in trials. And then
awesome.
And the prevent, that's what I was thinking, like, that's what I like thinking in those three categories is about, again, an earlier diagnosis and intervening early. And that's where, they've done this again in Alzheimer's and Parkinson's. They follow people at high risk who have the genetic form, but everything they learn in those people about, what are the biofluid or the digital or the speech app changes that happen before you're symptomatic, you can then apply it for sporadic disease. So we can, again, intervene much sooner or stop it. That would be amazing.
And that's what we're hoping for in our speech study, to see some real flags and digital biomarkers for getting that earlier diagnosis, and to hopefully understand the prognosis, because it's different for everybody.
Yeah, exactly. There is
Yep. Sorry to interrupt. Go ahead.
No, I was just going to say that there is, the first prevention trial has started in ALS, and though it is in, the SOD1 form of ALS, it's still a huge milestone to be intervening before symptom onset.
Well, since we have ALS patients all over the United States, all over the world, and a lot of them can't get to trials, is there anything that you would advise them to do? Not being able to get to a trial, so if somebody said, I just can't get to the trial, what else could I do?
Yeah, I think, that's such a good question. And my instinct is to say we need to make sure that there's a trial center everywhere, but that's not going to happen overnight. So I think it would be to find a doctor or a team that it can be proactive for you. Get on the treatments that we do have some data for, if you can, and then talk to your team about compassionate use. It is actually possible in most countries, not all countries, and you don't. Any doctor can ask their company about it, and I think there is this culture change now. The companies used to say no, but they don't say no as much anymore, thanks to a lot of work by you and others. But I do think we need centers, like it should, there really should be trial centers everywhere. So like in North America, we now have 134 centers in meals. That was one of the goals of meals, is to have,
Amazing.
but you're right, there are countries where they have zero.
Do you know how they choose a location?
For meal or for the trials, you mean?
Yes.
Yeah, so the sponsor of the study, whoever, whether that's a company or let's say for us, the Healy Center, selects the sites based on a couple things, qualifications, like that they see people with the illness and that they have the team. But one of the things we do at meals and the Healy Center is we always try to add 10 to 15% new sites, because if you keep going back always to the experienced sites, you're never going to grow anyone with experience in new areas. And some of the companies do that, but some are a little gun shy about doing that.
So it's not just based on, like, Nordstrom will go, which is a big department store out west. I don't know if they have them all over the country, but they go where it's highly dense, and the population is highly dense. That's how they choose their, and so yours are not just based on density, it's cases of ALS.
Yeah, it is. Yeah, it's a little bit of the number of people, but also the experience of the site, which, like I said, is good for getting good quality data, but it doesn't help get broaden access. So you have to do both, kind of have new sites as well as experienced sites.
That brings up a really interesting question. Can you tell us where is the biggest ALS group in the United States?
As far as people with the illness, you mean?
Yes. Yes.
Cluster.
Yeah. I don't actually. It's a good question. I know there's a lot in the Northeast, and we also have a lot more familial in the Northeast. But I do think it's distributed everywhere. I think there's huge holes in the Midwest of care centers, so we're probably underdiagnosing people there.
Mm-hmm.
But I do think it's all over the United States. There's a couple islands, in Japan and in the South Asia that have incidents. Yeah, but I don't know that there's a hotspots in the U.S. Now, the CDC would know that. I mean, part of the registry was to collect just that type of data, and to try to learn about environmental factors if there were some hotspots.
Did you guys? You probably did a trial on L-serine, I'm guessing.
Yeah, and I didn't, but I know in Dartmouth. So that is a good point, that there are up in New Hampshire, Vermont, around the lakes. There's definitely an increased incidence, and Dr. Stomel at in Dartmouth has been studying that this and doing an L-serine trial
with Dr. Cox. So, do you think that's algae, blue-green algae related, or I mean that's what they say, and it makes sense if it's along lakes, right?
Yeah. I think that this is why epidemiology is so complex in ALS. It probably isn't one thing. So there's been a couple studies which suggest it's 5 or 6 things that might happen to you in your lifetime to get to ALS. And if you carry a gene, that might account for like 4 of those, but you still need 2 other things. And so for some people, it might be that exposure to the algae, but other people, it might be, the being in the military or the head trauma. But it's not one, it's not like, smoking and lung cancer. There's no one really a thing that's high risk.
Is stress on that list?
I think so. I mean, just from my, 25 plus years of seeing people with ALS, I think it is both physical and emotional. But I don't know that there's a good epidemiology study on that, because I don't know that they ask those type of questions often. Yeah. What do you think? Is that from all the people that you've met?
Well, I want to just say for my case, I was building a kit house that I didn't know how to build. They just went bankrupt and gave me the kit, and I couldn't get the floor straight. And I went down in the woods and started to cry about it. And then I came inside and I told my wife, I said, Mona, I'm being driven crazy by this project. I can't do it. We have to get a contractor. Within 30 days, I started to lose the grip in my hand. So that was, to me, that was what triggered my ALS. And it just went up my arms and it went up my legs. And it started from that day. So I always try to talk to people about their stress level.
Stress
Yeah,
is ugly.
it does change your, you know, your hormones and your biology. So it's not unreasonable to think that.
Mira, what do you do to keep stress out of your life? You're so busy. You love what you do, clearly. You're amazing at what you do. So how do you keep the balance and keep yourself sane and healthy?
Yeah, no, it's a good question. I have I have a good husband I get to talk to, but I took up two hobbies in my 50s. I've never played a sport in my life because my parents were very anti us doing anything but studying.
Oh, that's funny.
So I took up soccer, and I play soccer 4 or 5 times a week with these wonderful new women I've met. And I'm not any good at it, but I really enjoy it.
What position do you play? I played left forward.
Oh, that was really good. And I'm defense, right defense.
Oh,
But
nice.
it's super fun, and I would say I've preserved my joints because I never really used them.
Right.
So
Oh,
What's
that's
the other
wonderful.
hobby?
Yeah.
I garden. I started to grow things, which is so much fun. But around here, I can only do that in certain months. So,
Yeah.
Well, there you go.
Excellent.
You're making new life.
McFinn,
You're
I'm sorry.
seeing new life pop right out of the ground. You're seeing brand new activities for yourself. You know, those are the things that are going to keep you healthy at your job. I hope that where he puts you out of a job one day and you retire to a great big garden and you teach your grandchildren how to kick that ball right through the goal.
that's right.
Yeah.
It's
Who's been your mentor?
Dr. Brown has always been my mentor. He's a really amazing person. I don't know if you have him on your list, but
Yeah.
really, I mean,
He's been on our podcast or on our webinar, and we do need to get a podcast of him.
Yeah. Brilliant and always there and always supportive. But to watch him, talk to a person with ALS and examine them, and I learned everything. Well, not everything from him. I learned a lot from him, and then I learned the rest from the people that I care for.
Yeah.
that is so important. I got a question that I need to ask. Do you give people ever a time limit on their life? Like you
No.
have 18 months?
No.
Okay, thank you. Thank you so very much.
Well,
I
first
think,
of all, who knows? I mean, we don't know that, and it's awful. Yes.
yeah, a doctor told me I had 18 months and it was like a pin picking me every week. I'd say, oh, I lost another week. And the mental stress of that was terrible. So thank you for seeing
Yeah.
past that.
Yeah.
No, I
Well,
know. Yeah, people come and tell me they were told that. I said no, and also what you said before, the packing your bags up. That no one should ever say it. Either of those things.
Get your affairs in order. Yeah. Well, if you could get a crystal ball, I know you're not a genie, but if you could get your crystal ball, what do you think the future of ALS might look like? And we can't put a time limit on the future either, but what do you think the future of it holds?
I think it's going to be a manageable illness, like I don't know if diabetes is the right example, or maybe multiple sclerosis is a good example, where we're going to have a lot of options, and you're going to have to be super subspecialized to know which option to give to which person, and we'll have the tools to guide us. I think that's first, and then I do think eventually we'll get to the early intervention and hopefully prevention.
There's hope.
That's wonderful.
There's hope.
It has really been a pleasure to have you come and share your wisdom and all the work that you've done through all these years, to have it all in your brain and you can pull it up out of that file cabinet so quickly, Doc. I mean, thank you. I'm sure that there's people in the world that you have no idea who are looking at you and saying, thank you for getting up every day and trying to make us tell ALS out the door. So we're proud of you. We're proud to be on your team. It's a wonderful, when I say we're on your team, it's just that we are working for the same goal as you are. And for that, all I can say is, I'm sure glad I met you.
I think
And how can we help you, Merritt? How can we be of help to you? Because you have a big job.
I think you're a help to me, and you're a help to all the clinics with ALS by all the work that you're doing and inspiring us. It's changed in the last couple of years, and I feel like I know people I've never met, including the two I met in person.
Yeah.
And there's so many people living with ALS that I feel like I know, and that we're working all together to solve this. It hasn't been always like that. So that gives me even more hope that things are going to change for the better.
It is a tight-knit community, and the people that we've met along the way. I mean, I've been on several Zooms with you, so I've been lucky enough to have the opportunity to get to hear from you and talk a bit with you. But it is a close-knit community, and you get to know people from all over. And the one big thing that I've gotten many things out of the work I do, but the biggest thing I would say is the people, like obviously being able to help others, but just connecting and meeting the wonderful people who work their butts off night and day to make a difference and make the world a better place than we all left it. It's so inspiring. It keeps me motivated. So thank you.
Thank you. So nice talking to both of you.
Yes, it's a extended family, and we all have the same goal. And so let's see it through.
Absolutely.
All right.
Have a great weekend. Thank you for having me on your podcast.
Thank you.
Thank you so much.
Thank you.
Goodbye for now.
Bye-bye.
Thank you for joining us in our journey of exploration and digging deep into the souls of those affected by ALS and those working tirelessly to help put an end to this devastating disease. Your stories and work matter so much to us and to so many. Keep sharing and continuing to help further the research in ALS so we don't have to see another person suffer. Are you a researcher, neurologist, pharma, or biotech company working in the ALS space? If so, we would love to hear from you. For more information, please visit everythingals.org, or you can contact us at info@everythingals.org. Thank you.